Okay, thank you for your kind introductions. And then it is very great honor for me to speak my presentation here in this beautiful Nimbin cities. And then I will give a short talks about the advanced HCC and portal vein thrombosis, and then provide the 6 real clinical cases to for your discussions like that. Actually, so the advanced HCCs, according to the BCHC system in 2022, still the standard treatment of this disease is systemic therapy. So now, the first line therapy is ateju. It's very difficult to pronounce atezolizumab like that. Yeah, not sorafenib now. And then according to the Bridge study about the global patterns of HCC management, up to 50% HCC patients are diagnosed and advanced stages. So this advanced HCC usually shows a poor clinical course due to the more chance to have intrahepatic metastasis and the tumor recurrence and fewer therapeutic options. So advanced HCC showed much shorter overall survival, and the main portal vein tumor thrombosis showed a poorer prognosis compared to branch PVTT. And then the sorafenib was the standard treatment for the advanced HCC, but there was no significant survival improvement before and after using the sorafenib in the advanced HCC like this. Therefore, many other therapeutic options, including the TACE, radioembolization, RFA surgery, and the radiation therapy, has been adopted for treating advanced HCC in real clinical practice. So let's start with the first case. The first case is a typical one of the advanced HCCs. So infiltrated tumor here, and then the right portal vein tumor thrombosis, and then they extended to the main portal vein tumor thrombosis like that. And then this is a conventional angiography, so you can see the large infiltrated tumors and then portal vein tumor thrombosis here. And then yes, this is a big infiltrate tumors. And then you can see the PVTT here again. And then I choose hepatic arterial infusion chemotherapy. We call it HAIC or HAIC. So why main reason to choose this treatment was the advanced HCC with the main portal vein invasion. And then the liver function was not good, so child B7. So of course, systemic therapy can also be selected, but the HAIC or HAIC was selected for rapid tumor mass control. So we use the 5 French port and catheter by the right femoral artery, and then the GDA and the right gastric artery coembolizations. And then we can infuse the high dose of the cisplatin and the 5-FU as a regimen. So this is the result of the hepatic arterial infusion chemotherapy in this patient. The serum level of the PVCAR, one of the famous tumor markers for the HCC, dramatically started to drop after 3 months. And then after 12 months, the PVTT almost regressed, and then showing significant anti-tumor effect. So she is still alive without any tumor recurrence for more than 5 years after treatment. So HAIC, we can call it the hepatic artery infusion chemotherapy via subcutaneous arterial port, has been adopted for HCC treatment over 25 years in the Taiwan, Korea, and Japan like that. And then the rationale of this treatment is higher local drug concentration and the fewer systemic toxicity and the better response than the systemic therapy. And then there is no emboli effect. So much safer in HCC patient with the PVTT compared with the TACE. So usually the indications of the HAIC is a portal vein tumor thrombosis, especially in the main portal vein tumor thrombosis. And then sometimes we can use this once in the case of the TAC refractory. And then the TAC refractory, we can define that within 3 months after TAC, there is less than 50% of the lipid accumulation or progressive disease with the multiple new lesion. So according to comparison studies from my hospital, HCC HAIC showed a longer survival and then the time to progressions compared with the sorafenib. And then this is a RCT study from Korea showing the similar result like that. So for continuous and repeated hepatic arterial infusion of the chemotherapy, this percutaneous hepatic arterial port system is always necessary. And then this is really implanted by the interventional radiologists like us. So hepatic arterial redistribution is important in order to terminate extrahepatic collateral, extrahepatic distribution from the hepatic artery, and then to unify the multiple hepatic arteries like that. So in these patients, we perform the non-hepatic artery embolizations, accessory left gastric artery, and the right gastric artery, and GDA, and then the gastroduodenal and the gastroepiploic artery like this. So this is the final result of the coil embolization. And then this is angiography, infusion angiography. So we can infusion of the chemotherapeutic agent, high dose level, and then like this angiography. So we can choose the left subclavian artery access or femoral artery access according to the status of the celiac trunk. And then I want to mention about the current status of the HCC in Korea. HAIC is indicated in advanced HCC, especially with the main portal vein tumor thrombosis or progressive HCC after TACE. So it is true that the recent systemic therapies are reducing the number of the procedures in advanced HCC, but nevertheless, many Korean physicians will still advocate the HAIC because a better tumor response of HAIC may provide a survival benefit in patients with advanced HCC. So let's move to the second case. So this is a 77-year-old woman has large infiltrate tumors here, left lobes, and then the left portal vein invasions. Yeah. So this is a conventional angiography like that. Yeah, here. And then we use it, we perform the radioembolization here in these patients. Because of that, advanced HCC with only left portal vein invasion. That means the tumor and the PVTT is localized and the left side only. And then the liver function is quite good, the child A6. So this is SPECT from the technician 99 MAA, and then lung shunt is 6%, and then TN nation is 3. And then after some coil embolization, so we infuse it separately can say the S2 segmental artery and then the S3 segmental artery with the third spear. So this is a very famous product with the resin with the Y90. And then the tumor dose was the 150 gray. And then this is the result. After 6 months, the mass was markedly decreased in size. And then at 12 months, the tumor marker was almost normalized. So radioembolization is very effective, especially in case that the tumor and the PVTT are confined to the single lobe and then the right or left hemilobe. We call it the unilobar disease. And then we should consider the various complications from the radioembolization. Actually, so radiation pneumonitis is the most serious. So this is a case of the radiation pneumonitis in the radioembolization. And then you can see the bat wing configuration even in radiography and chest radiography and then CT. So sparing the peripheral and the highlight region like this. So treatment of the choice is a steroid, but many cases are very fatal. So we should consider the radiation pneumonitis in radioembolizations in most cases. So this is the third case. This 85-year-old man has a poor liver function, so only B7. And then the tumor size is 12 centimeter here, and S5 and S8, and then there is some segmental PVTT. So we selected the super-selective radioembolization in these cases because of the poor liver functions for sparing of the large normal liver parenchyma. Actually, so we use those lower radioembolizations. So these patients cannot survive because of the hepatic dysfunction. So super-selective approach with the radioembolization is very important. So yes, this is a convincing images, and this is an EMBO guide. And then you can see the three feeding branches here. And then we treated the patient with Y19 at the three separate branches like that. One from this branch, and then another from this branch, and then the last branch is like that, this one. So we separated infusion, but the total dose of the Solspierce is maybe 3.5 gigabecquerel, and then the estimated tumor dose is 150 gray. So after 12 months, the tumor response was PR like that, and then the remarkable point in this case that this normal parenchyma is completely preserved, and then later showed some compensatory hypertrophy. So we can spare this area even with very good liver functions. So super-selective radioembolization is very useful for sparing normal parenchyma, so particularly in the patient with poor liver functions. And then this is an 89-year-old man has a huge nodal HCC to the right lobe. And then the problem is there is intrahepatic metastasis here and the same lobe. And then there is also segmental PVTT here. So this patient was treated by the split session, many sessions with conventional TACE. And then because of the huge tumor burden, and then the unilobar intrahepatic metastasis, but the liver function is quite good. So we can use the conventional TACE here. And then we started to treat patient with the conventional TACE, and the tumor was supplied from the all right hepatic artery like this. But in this time, so we only these two branches was treated by the conventional TACE, and then this is the result like that. So accumulation lipidors only here. And then the second time, so after only 2 weeks, every laboratory findings was normalized, and then we can use the conventional TACE again. And then at that time, so we embolized the rest branches of the right hepatic artery, and then this is the result. So we can control the main mass and then the intrahepatic metastasis nodal as well. So after 2 sessions of conventional TACE, the tumor response was also like this, and then many lipidol accumulations here, and then the tumor markers are markedly decreased like this after 2 months. However, this angiography showed that the significant area of the viable tumor here. So this patient treated with combined HAIC, HAIC. So I used the 5 French catheters, and then we infused the HICs from here, and then we use the regimen of the cisplatin and then the 5-FU. and then this is the final result. So after HALC, the tumor mass was more reduced, and then the tumor markers almost normalized like this. So in this elderly patient with a huge tumor, received the conventional TACE at once, and then he must have suffered from the significant complications. So in case of a huge advanced HCCs, we can use it conventional TACE split session, and then we also can use it combined HAIC after any intra-arterial systemic therapy if the hepatic vascularity is intact. So this is the fifth case. This 84-year-old man had a large tumors at the right lobe and then the medial segment also, and the segmental PVTT here. And then tumor markers are very, very high, like the PVTT are over the 674,000, like that. And then the problem is this tumor is supplied from the hepatic artery and right inferior phrenic artery at the same times. So we use the radioembolizations, and then we treated the right inferior phrenic artery with a blended embolization like that. So this is a SPECT study, so hepatopulmonary shunt is only 10%. So we performed the blended embolization with this microsphere, so for the right inferior phrenic artery first, and then we use the TerraSpheres 7 gigabecquerel for the right hepatic artery. So we make some intratumoral redistributions of the vascular supply like that. So this is the result. After 6 months, the tumor masses decrease in size, but still has some tumor viable here. And then this is angiography. This is the initial angiography, and then this is 6 months follow-up angiography. So you should know that many vascularities has regressed, and then the tumor marker also decreases. But there is a tumor, still tumor here. So at the time, we use the additional treatment like TACE or DEP-TACE like that. So this is angiography, and then these tumors were also treated by the conventional therapy, TACE, including the doxorubicin and the lipiodol and the gelatin microparticles. So this is the 9 months result, and then this is 15 months follow-up. So you can see that there is no residual tumors here, and then the PVCA and then alpha-fetoprotein like tumor markers almost normalized. So extrahepatic tumor supplies can be managed by the before radioembolization or by the particle-based blend embolization, or we can use it to separate the infusion of the Y19. So initial radioembolization combined with conventional TACE was very beneficial in this patient. And then if the partial response was obtained 6 months after radioembolization, we can consider additional treatment such as TACE, additional repeated radioembolization, or radiation therapy. So in my experiences, combined TACE is very useful and then cheap. I mean the cost effective, and then the less post-embolization syndromes like that. So this is the last case. So this 50-year-old man has a poor liver function, and the right lobar infiltrated with HCCs with the segmental PVTT, and then the 2 nodular HCCs at the left lobe like that. So this is a bilobar disease. And then his liver function is very bad, B6 or B7. And then there is a segmental PVTT. So we can, at this time, we can use the liver transplantations. The problem is too advanced. So we should liver transplantation after downstaging. So we performed the downstaging study with the conventional TACE like that. So the first session of the nodular HCC for the left lobe and then right lobe like that. And then for the segmental PVTT, we use the SB radiation therapy. So like this. And then we also use the conventional TACE for the residual tumors like that. And then this is the final result. Yeah, you can see that every tumors accumulated with the lipiodol, and then the segment PVTT is also accumulated with the lipiodol, and then the PVCA alpha fetoproteins was normalized. That means the downstaging is successful. So we performed the living donor liver transplantation, and then the pathology report that the 95% tumor necrosis, and then only minimal perivascular viable tumors, and then the liver transplantation was very successful, and then he is still alive now. And then from the case 6, we should know that in advanced stages, living donor liver transplantation is also effective treatment modality after downstaging. So we can perform downstaging with the conventional TACE, radioembolization, HAIC, or radiation therapy. So I just summarized the case. Large infiltrate tumor with the main PVTT and the poor liver functions HAIC, we use it. Large infiltrate tumor, ipsilateral lobar PVTT, and the good liver function, we can use the radioembolization. Huge tumor with the segment PVTT and the poor liver function, at that time, so we should use the super selective radioembolization. Huge tumor with the segment PVTT, intrahepatic metastasis, and the good liver function. So we can use the split TACE, and at these cases, we combined with the HCC, huge tumors with the lobar PVTT, right inferior supply, and then the good liver functions, we can use the radioembolization, and then the additional TACE after the blended embolization of the right inferior artery, diffuse nodular infiltrable HCC, lobar PVTT, and the poor liver functions. We can use the living donor transplantation after downstaging. So this is my take-home points. So many intra-arterial therapies are still performed for better tumor response and the longer survival in advanced HCC with PVTT, including the blended embolization, TACE, and the radioembolization, and the HAIC like that. So which intra-arterial therapy to adopt should be decided in consideration of the liver function, and then the size and the location of the tumor, and then the degree of the PVTT. Okay, thank you. 감사합니다.